Well, let's have a look at a few clinical cases of wounds now. Now this first slide shows a human bite. And first of all, we can see there's some markings around here. Now, a few days ago, this patient was examined and there was found to be an area of cellulitis. And it was marked off, so we knew how far the cellulitis had spread. And this is a good idea, because if you mark off where the boundary of the cellulitis is, the reddened area, you can see if it's spreading. Because if it spreads, it can become a life-threatening condition. But here I'm pleased to see that the inflamed area is now well within these boundaries, because the patient's been on antibiotics for the last few days, and it's caused the cellulitis to regress. And if we look at the colour of the skin there and the colour of the skin there, it looks pretty well the same. So I'm pleased to see that that cellulitis is under control. But we do have an inflamed area here which is swollen, and what we're dealing with here is an abscess. Now, an abscess is a cavity that's full of pus. It's surrounded by dead or inflamed tissue. Or if it's an old abscess, it might even be surrounded by fibrous tissue. And very often, if there's pus about, we need to let it out. But we need to do so at the right time. Now, the phagocytes, like the macrophages and the neutrophils, will be moving to this area to consolidate. So we need to wait till they're consolidated before we drain the abscess. But then again, once the abscess is consolidated, we don't want to wait too long, because this is infectious and it can start tracking, or indeed there could be further cellulitis. So here we see that the area is being cleaned with betadine, which contains iodine. And as far as I know, iodine kills all known bacteria. The patient's just been given a local anaesthetic. It's been incised and all this pus can now drain away. But of course we can't close this wound because there's still infection inside. So we need to use healing by secondary intention. And we see this wound is packed. We'll need to revisit this wound on several occasions to repack it, to allow it to heal by secondary intention. Well, here we see quite a nasty burn in a child. We can see that there's dead epidermis there. This is a partial thickness injury. Now, burns can be superficial, only affecting the epidermis, or partial thickness burns burn into the dermis. You can get superficial dermal or deep dermal, or indeed burns can be full thickness, where the whole layer of the skin is completely burnt and necrosed, including the dermis and the epidermis. Now, it's important to know if there's other tissues which are complicated in a wound. And perhaps the most extreme example of this is an open fracture. The old-fashioned term for open fracture is a compound fracture. And here we see the very nasty injury with bone exposed to the outside air. So a compound fracture doesn't have to be as obvious as this. A compound fracture is any time where the fracture line is if there's a continuous wound between the fracture line and the skin, or indeed between the wound and a body cavity, allowing infection to get potentially into the bone, because that carries with it a risk of osteomyelitis, which we are very keen to prevent. So we certainly need to get our orthopaedic friends onto this. They'll take this patient to theatre, clean this out, get rid of the necrotic tissue, and fix the bones. Now, this is a fairly common sort of injury, a contusion. A contusion simply means a bruise. And what's happened is normally the small blood vessels, the capillaries, are ruptured. Blood leaks out into the interstitial spaces. That blood will deoxygenate, and we'll see that as a bruise. You can also get bruising from large vessel injury if there's blood in the tissue spaces. What I'm concerned about here, actually, this is a seatbelt injury, so this patient's obviously been subjected to a lot of forces. So I'm just wanting to make sure that all our organs are quite secure inside. So, for example, there's a liver in here, isn't there? We don't want that to be damaged. We need to bear in mind what is underneath the obvious wound. If there's organ damage, there might be laceration or rupture to the liver. There could be blood in the peritoneal sac, a hemoperitoneum, with very important management implications for our patient. This is a crush injury. Now with a crush injury, there can be inflammation inside muscle compartments leading to the compartment syndrome, and also when the individual muscle cells are crushed, the cell membranes of the individual muscle cells are damaged, and there can be release of myoglobin into the blood with a myoglobinemia. We call this condition rhabdomyolysis. Rhabdo relates to the skeletal muscles. Myo, of course, is muscle, and lysis is breakdown. So crush injury, you've got the local injury, of course, which needs address, but there's also the risk of compartment syndrome, noted by excessive pain, and there's also the risk of myoglobinemia and rhabdomyolysis. Now here we're looking at a degloving injury, in this case on a leg. Most commonly you tend to see these in fingers, and often the patient will report that their ring was caught in some machinery, and as the ring was ripped off from their finger, it took the skin off the end of the finger with it, almost like taking off a glove. And we see here the skin which has been evulsed. This is a type of evulsion injury. It means a tearing. We can see it's been torn off from the fascial plane here. This is the muscle fascia, and we can see that there's some subcutaneous disrupted adipose tissue as well. And as the skin is torn off, it severs the blood supply going from beneath up into the dermis and the epidermis. So what would we do about this sort of injury? Well, actually we can treat this as a skin graft. So this, well, first of all the wound needs cleaned and debrided, and once that's clean, this skin can be pulled back up, it can be sutured into position, and then we want some light compression bandage over the whole thing. The reason we want a light compression bandage is that if we haven't got some compression, there's a risk we're going to get some hematoma formation, disrupting the blood supply between the underlying tissues and the anatomically realigned, replaced skin. But if we have too tight a compression, that's going to compress the small capillaries and reduce the perfusion of the wound. So we'd want some light compression on that, and then we'd need to keep an eye out to make sure that this skin remained viable. But very often it does, and we can expect fairly good results from degloving injuries as long as they're well managed. Now these next few slides show the influence of systemic disease on wounds, and a systemic disease that we see on a daily basis that affects wounds and wound healing, of course, is diabetes mellitus. And in this case we see a diabetic ulcer. This is in a patient with sensory neuropathy. Now diabetic wounds and ulceration can be made worse by ischemia, because there can be macrovascular ischemia or microvascular ischemia. And as well as that, as well as being peripheral vascular disease in diabetes, there can be peripheral neuropathic disease. So there can often be a neuropathic component. Now the peripheral neuropathy can be motor or sensory. The sensory is the most common. This is an example of a sensory one. This patient wasn't complaining of pain, and because the nerve supply to the leg was disrupted, the small vessels in the leg spontaneously vasodilate. So actually the peripheral perfusion here was actually quite good. The limb was a nice red colour, and it was well perfused and felt warm. But that left this primarily sensory neuropathic ulceration here. Now here we see a fairly typical diabetic plantar ulcer. Plantar just means the lower surface of the foot. The converse would be the dorsal surface, which is the upper surface of the foot. But it's very typical to see diabetic ulceration on this plantar surface. And we notice that there's not a great deal of inflammation around about this. There is maybe a little bit there, but this is fairly typical. Again, in many diabetic wounds, you don't get the typical erythematous inflammatory response. And this is because of the basement membrane thickening on the arterioles, the capillaries and the venules that can prevent the normal vasodilatory inflammatory response. Now here we see another diabetic wound. Here there's a sinus formation, an artificial cavity has been formed as a result of infection. And this of course has significant implications, because in here there's going to be infection. So diabetic sinus formation. And because this patient is neuropathic, it didn't actually hurt at all to explore this wound in this way. And here we see the X-ray, which is one of the great risks in diabetes, osteomyelitis. Just for orientation, we've got the talus tibia, and we can see the calcaneus. Now, we follow the line of the calcaneus around, we can see it's grossly disrupted with osteomyelitis, and this will be very difficult to treat. This really points out the great importance of recognising very minor diabetic lesions at an early stage, getting them treated before they develop into osteomyelitis. Now, another disease process which can cause wounds is meningitis, because not so much meningitis, it's the meningococcal infection actually, because meningitis can be caused by different infections. But this is caused by meningococcal sepsis, damaging the vasculature, and we've got gangrene from meningococcal sepsis. Another disease process that can occur in chronic wounds is carcinoma, squamous cell carcinoma. So this is a chronic leg ulcer, and it's developed a squamous cell carcinoma, probably in this bit round about here mostly. Another disease which can cause lesions is syphilis, and here we see a unpleasant syphilitic ulcer. Yeah, now these next few shots are on foreign bodies. Just give you a minute to orientate yourself there. So here we see the vertebrae, the base of the skull. These are dental fillings in the mandible, superior maxilla here. And I don't think I'm going to give a prize for this one. You can see the air gun pellet there lodged in the neck. Take another view and you see it again just here. Of course, the key thing here is thinking about what important structures, arteries, veins, nerves, could be involved as a result of this foreign body. Now, this shows the importance of really exploring your wounds properly, because this patient was actually admitted with this huge piece of glass in their leg, and after 10 days the wound wasn't healing, so they came back and this piece of glass was still in the patient's leg after 10 days. So no surprise at all that it wasn't healing. Wounds aren't going to heal with foreign bodies in them. So make sure wounds are properly explored and any foreign bodies are removed before the patient is discharged from your initial treatment. No prizes for spotting the foreign body there from a nail gun. Wooden splinters, very satisfying to take out. Patients always appreciate it. This is quite a common sort of wound, pretibial flap, where the skin is like peeled off in a flap, often in front of the tibia because of the bone underneath. And with a bit of patience you can close it up quite nicely. The hope is that this will be viable, and there's a good chance that most of this flap will be viable and the patient can have a primary healing in this case. Scalp flaps, another fairly frequent injury. Now the scalp has a very good blood supply. Blood comes in from here and from here and from here. It comes in from all directions. It's described as being like a crown. So once this is cleaned and sutured back into place, we could expect viability of the flap and hopefully good primary healing. Neatly closed flap on a thigh there. And just looking at this skin here, it's obvious that this skin is viable. Okay, there's some inflammation around there, but again, I would expect that to be viable, and I would expect primary healing from that flap wound. Hematomas, we see these reasonably frequently, especially in older people. So here we see a hematoma on a leg, and here we see that the hematoma has been evacuated. Now, I'm a bit suspicious that this isn't going to be viable, but we'll see what happens on that one. But good to get rid of all this stagnant blood, because alternatively, if it was left in, there's a pretty good chance that that's going to become infected. Incised wounds are made by sharp cutting objects. They're made by knives, they're made by sharp pieces of metal, they're made by sharp shards of glass. So an incised wound is cut with a sharp object. And the key thing with an incised wound is that if someone's cut by a knife or a sharp piece of glass, that will cut through pretty well anything. So it will cut through potentially blood vessels. So we have to make sure there's no blood vessels have been cut through. It will cut through nerves. That's why we have to examine for sensory loss in all of the distal tissues to see if there's any nervous damage. And it will cut through tendons. That's why we have to make sure the patient can close and extend their fingers, because the incised wound can just cut through the lot. Another fairly common type of incised wound on a finger. Now, the converse of an incised wound, sort of the converse of an incised wound, is a laceration. And here we see a laceration on the knee. Now, in an incised wound, we have the wound because it's cut. There's a cutting with a sharp object. But with a laceration, there's been blunt trauma, and this wound has not been cut open, it's burst open as a result of the blunt trauma. So whereas with an incised wound, we have to think about, has it cut through vessels, has it cut through nerves, has it cut through tendons? With a laceration, there's been a force exerted into the tissues which have caused the skin to burst open. And indeed, underlying structures such as livers, kidneys and spleens can also be lacerated as a result of blunt trauma. So we've got to think about what's underneath it, because if there's been a laceration, it means there's been a lot of force impacted into the tissues. Perhaps particularly important with the head. If there's a laceration to the scalp or other part of the head, that means there's been a lot of force going through the head, with the possibility of an intracranial lesion. So this wound should clean up and be closed by primary intention, but it's a laceration, it's caused by blunt trauma with a lot of force, as opposed to an incised wound. So always think about what tissues could be damaged underneath. Now, when we're assessing any wound, it's very important to look out for the possibility of wound infection. And this burn's actually become infected. It's much darker red, and there's some redness round about it. So when we're redressing wounds especially, we've got to look for infection. So we need to look at the wound colour. Has that changed? And we need to look at the exudate. Is there an increase in the amount of exudate? Or has the wound become smelly? Or is there surrounding cellulitis or even tracking away from the wound in the lymphatics, with the possibility of lymphadenopathy? Or is it simply that the wound is not healing? If wounds don't heal, that can be the consequence of infection, because infected wounds don't heal. Or is there particularly friable, dark red granulation tissue that can indicate infection? Or increased pain. And we might need to do a culture and sensitivity in the wound to look for any infecting organisms. And then, of course, we need to look at the patient systemically to see if there's any possibility of the development of sepsis, because a badly infected wound can lead to sepsis. And the clinical features of this are well rehearsed. Is the patient's temperature greater than 38? Is their respiratory rate greater than 20? Is their heart rate greater than 90 at rest? Do they have altered mental status? Is their white blood cell count greater than 12,000? Or is their fasting glucose greater than 6.6 when they are fasting if it's a non-diabetic? The same as sepsis with any other cause, but always bear it in mind. Well, pressure ulcers certainly get these, don't we? Note this nurse is wearing a watch and nail varnish, none of which are actually allowed. So don't let me catch you doing that. But pressure ulcers, common sight there on the heel. Anywhere the pressure of the body is transmitted down through the patient onto a hardish surface. So these should be prevented. Well, we don't want hideous things like this. Very large sacral pressure sore. Purely as a result of paralysed, or well, not necessarily paralysed, immobilised patient being neglected for a period of time. That one's healing up a bit now, which is nice to see. Now this one was from thromboembolic deterrent stockings, just stockings that, so pressure sores aren't just pressure through the weight of the body, this was things that are tight on the body. This of course should never have happened. But now we have a wound like this, it needs to heal by secondary intention. Puncture or penetrating wounds look very small on the outside. The question is, of course, what has this done on the inside? How long was the blade that made it, or whatever it was that made it, and what tissues could be damaged inside? So as we see, this is in the chest, so I'm going to be worried about pneumothorax, I'm going to be worried about large vessel injury, and we're now into an advanced trauma life support situation. We do see self-inflicted wounds. Patients make wounds themselves, sometimes in this case on the wrist, and we have to try and find out what is the psychological or psychiatric cause of such self-mutilation. Venous ulcer, I think this is the last one of this sequence. Venous ulcer. This it needs a bit of debriding here, doesn't it? You just want to get all that dead tissue picked off. But the reason I've shown this is that it's not just the wound, we have to think about other things as well. So we think about the systemic condition of the patient. But with venous ulcers, unless we put on compression to get rid of the venous stasis, we're unlikely to heal the ulcer. So is there anything ongoing, any ongoing factors that can delay wound healing? In this case, venous stasis. So it's very matter of thinking about our patients holistically.